marijuana and epilepsy. It has been a frequently asked question.
The broadcast is now starting. All attendees are in listen-only mode.
Good evening. My name is Dr. Douyon. We're going to talk today about the use of marijuana and epilepsy. It has been a frequently asked question over the last several months, and therefore we want to continue the conversations that we've been having privately with our patients in a more public forum. While it's been known for decades that people self-medicated with marijuana, the issue of marijuana and epilepsy was brought to the national forefront last summer when CNN aired its special on the topic weed. In order to begin to understand the potential benefits of marijuana, we need to all be on the same page with understanding the mechanism of seizures. So I'm going to begin this presentation with a brief overview of seizures and epilepsy, and then we'll talk about the endocannabinoid system, its mechanism of action, its impact on the brain and theoretical role in epilepsy, as well as the politics with the use of medical marijuana. So what is a seizure? A seizure is due to a sudden surge of electrical activity in the brain. The electrical activity in the brain tends to be caused by complex chemical changes that occur within the nerve cells. And it's through this electrical activity that neurons tend to communicate with each other. They send messages to each other. It's through this electrical activity that we're able to move, to speak, or to even think. It allows us to be who we are. And neurons, they either excite or inhibit other neurons from sending messages. And usually there's a balance between excitation or inhibition. When a seizure occurs, there's a chemical change that occurs that leads to a surge of electrical activity. Epilepsy, by definition, is 2 or more unprovoked seizures. It's the 4th most common neurological disorder and affects people of all ages. It's used interchangeably as seizure disorders. It's characterized by unpredictable seizures. And it's a condition that has a wide range of seizures because different parts of the brain control different things, such as movements and behaviors. And this tends to be really important because the initial management of somebody with seizures begins with identifying which therapies will work, whether it's conventional treatment or a potentially new medication like marijuana. And in order to do this, we really need to understand the person's seizure type. So therefore, in sort of broad terms, seizures can be classified into 2 major categories. You have generalized seizures, where the entire brain seizes, or you have focal seizures, where the seizures originate from one area. It may spread, but the initial surge of electrical activity begins in that one area, in that one region, in that one lobe of the brain. Not only is this the reason that seizures vary, some seizures involve a twitch of the arm, while others result in loss of consciousness and convulsions. Some are hardly noticeable, while others are totally disabling. But this information is also crucial when it comes to managing epilepsy and choosing therapies. We said before that seizures are caused by an abnormal surge in electrical activity. But there's a long list of things that can lead to that abnormal electrical firing. These include tumors, strokes, head injuries, new and old, toxins such as alcohol, cocaine, amphetamines, medications, including abruptly stopping anticonvulsants, infections such as brain abscesses, meningitis or encephalitis, metabolic, so changes in calcium and sodium, as well as genetic causes, like the children who were featured in CNN's documentary. With all these different causes of epilepsy, we have a few different treatment options. The vagus nerve stimulator, which sends an electrical impulse to the left vagus nerve in the neck, through an implanted device. Vagus nerve stimulators have been shown to affect blood flow and to affect neurotransmitters, which then affects electrical activity. We have medications, and there seems to be an always growing list of anti-epileptic medications. And I'm not going to bore you by going through each one, but what's important here is the mechanism of action of all these medications. Because for the most part, what they all do is work on ion channels, whether it's sodium, potassium, or chloride. And all these modulate the electrical activity within the neuron to decrease the risk of the surge in electrical activity. Other treatment options include dietary therapies, which mimic states of starvation, deprive the body of glucose by restricting carbohydrates. The human body then starts to break down fat into ketones, and it's thought that these ketones affect neuron and neurotransmitters, and therefore alter electrical activity. Epilepsy surgery is an option for focal epilepsy that doesn't respond to medications. Here we identify the area where the seizures are coming from, and if it's an area that can be safely removed and doesn't result in neurological deficits, then it's taken out. – 20 to 30% of all people with epilepsy will have medically intractable epilepsy. Now, no single step in the treatment of epilepsy actually defines somebody as intractable. However, after each drug failure, the statistical probability of seizure control by adding the next drug becomes lower. The goal of therapy is always to reduce seizures, to avoid adverse effects, and to increase quality. But only about 10% of people who haven't responded well to monotherapy with 2 appropriate anti-epileptic medications or a combination of 2 drugs will respond to a 3rd drug. And new anti-epileptic drugs aren't necessarily more effective than the older ones. Now, there is a group of people, because of their epilepsy syndrome, who have medically intractable epilepsy. These are people who have syndromes that consist of developmental delay. They're on the autism spectrum. They have difficult to treat seizures. These are the types of people that were featured in CNN's documentary Weed. These are people with horrible seizures and cognitive impairments. And experts have argued for years whether it's the impaired brain that produces the constant seizures or whether it's a constant seizure that impairs the brain. To some degree, it's probably both. In these patients, the sudden surge of electrical activity is constant. It can arise from certain regions in the brain and spread, or it can evolve from the entire brain. People with epileptic encephalopathies can have hundreds of seizures per week, and our more traditional therapies have failed them. This is the EEG of a child who has an epileptic encephalopathy. What we see here is just a constant seizures. And so this is why people are looking for an alternative therapy, like marijuana. And this particular strain of marijuana, Charlotte's Web, is named after the little girl who was featured in CNN's documentary on weed. And she is the first child in Colorado to ever obtain medicinal marijuana. She had one of these epileptic encephalopathies known as Dravet syndrome. She was having up to 3 seizures per day. And after receiving a very specific form of medicinal marijuana, her seizures drastically decreased to approximately 1 per day. Now, marijuana is a pretty complicated compound. It contains about 60 pharmacologically active compounds, and these are called cannabinoids. The THC was first isolated in 1964, and this is the psychoactive compound. This is the compound that gives the feeling of well-being, the feeling of being high, whereas the CBD was isolated in 1963, and that's a non-psychoactive compound. The ratio of these two compounds is what determines therapeutic versus psychoactive effects. When THC is higher in concentration, one develops the psychoactive effects of the drug. Whereas the CBD is higher, the effects are more therapeutic. Some people say that in order to achieve a benefit from marijuana, actually all of the compounds need to be present in that drug. But for the little girl Charlotte that we saw in that documentary, she obtained a very specific form of medicinal marijuana. And in this strain, the CBD was in high concentrations and the THC was in very minimal concentrations. The presence of CBD receptors in the brain is what produces many of its effects. And these receptors tend to be distributed widely throughout the brain. When marijuana attaches itself to the receptors, it modulates the cells. It changes the cells. It begins changing the way that we move, changing our coordination, our learning and memory are affected. Our appetite is affected. Our cognitive functions, such as our judgment and our sense of well-being, are affected. The discovery of the CBD receptors within the brain led to the realization that there is a system for CBD within our brain, which occurs naturally. We said earlier that the electrical activity in the brain is caused by chemical changes that occur within the neurons. And if we look at this picture, the presynaptic cell here at the top communicates with its nearby cell at the bottom. And it does this through neurotransmitters, or these little chemicals that it releases from one cell to the other. And when those are received by the postsynaptic cell, it sets up a chain of events that leads to an outcome depending on where that cell is located within the brain. So this is a natural process that occurs within the body. And with exogenous marijuana, so when we take marijuana, it tends to bind to the presynaptic cell and it changes it, preventing it from releasing chemicals to communicate with its nearby cell. The human body contains two types of receptors called CB1 and CB2. CB1 receptors are primarily found within the central nervous system, so in the brain and the spinal cord. The theory as to how this relates to seizures is that the CB1 receptor regulates neuronal hyperexcitability. So the more excitable a neuron, the greater the electrical activity. The CBD that the body makes is in response to increased excitability. So with seizures, there's always an accompanying neuronal hyperexcitability that triggers the body to make its own CBD. So this then activates the receptor, and this causes chemical changes which affect then the electrical activity. But this is just a theory, because there are no studies that have evaluated the role of this system in an intact epilepsy model. In fact, what limited studies there are on medicinal marijuana really tend to explore the effects of smoking weed as opposed to its medicinal value. So, in this book, Tinkers, which was a Pulitzer Prize-winning novel, the protagonist describes his father, who had epilepsy. And his father compares his seizures to electricity and lightning. He asks, what is it like to be split open from the inside by lightning? And he provides one answer. The actual seizure was when the bolt touched the flesh, and in an instant so atomic, so nearly immaterial, nearly incorporeal, that there was almost no before and after, and Howard became pure unconscious energy. And so, just to review, that our body has its own inherent CBD system, and the CB1 receptor regulates neuronal excitability. So increased excitability, which is associated with seizures, tends to cause a release of CBD. But again, this is only a theory because there have been no studies that have actually shown this. The CB1 receptors tend to be concentrated in the hippocampus, in the cerebral cortex, in the basal ganglia, the cerebellum, the spinal cord, and peripheral nerves. The CB1 receptors tend to be absent from the brainstem. And some people say that because it's absent from the brainstem is the reason that we never hear of somebody overdosing on marijuana, because it doesn't affect our vital functions like respiration and heart rate. Now, even though there have been few studies on the benefits of medicinal marijuana, what we do know is that the areas in which the CB1 receptors are concentrated are what cause the effects of smoking weed that we've all heard our entire lives. Its effect on the hypothalamus is what contributes to the increased appetite. Its effect on the cerebellum and basal ganglia is what contributes to people moving slowly, thinking slowly. Its effect on the cerebral cortex, especially the prefrontal cortex, is what affects planning, decision-making, and the inability to complete tasks. That's what contributes to apathy and loss of interest. It's its interaction in the dopamine reward system that makes it pleasurable and addictive. It's also its role in the dopamine reward system that contributes to the creativity that people often report. We also know that there are some long-term consequences with marijuana abuse, especially when started during adolescence. Adolescence is a time in which the brain is undergoing a lot of changes. It's not fully mature. It doesn't reach maturity until about the mid-20s. And what we do see is that with earlier use, there's decreased brain metabolism, white matter is impaired, IQ decreases, the risk of strokes increase, and psychiatric disorders also increase. So while the studies on the benefits of medical marijuana are limited, there was recently a team of researchers who were given the task to determine the efficacy of medical marijuana in several neurological conditions. And the question that they asked was, does marijuana improve the spasticity in patients with MS? Does marijuana improve central pain and painful spasms in MS? Does marijuana have an impact on bladder dysfunction in multiple sclerosis? Does it improve involuntary movements, including tremor in multiple sclerosis? Does marijuana improve the dyskinesias of Huntington's disease, levodopa-induced dyskinesias in Parkinson's disease, cervical dystonia, and tics of Tourette syndrome? And does marijuana decrease seizure frequency in epilepsy? And so what they did was they searched online through databases Medline, Embase, PsycInfo, Web of Science, and Scopus, and they found 1,729 abstracts. And then they excluded all of the surveys, the case reports, and series of non-placebo controlled trials and found 63 articles, 33 of which met their inclusion criteria. And when they asked, does medical marijuana decrease seizure frequency, what they found was that there were no studies where there was evidence from any randomized controlled trials. And in fact, there were no randomized controlled trials at all done looking at marijuana in epilepsy. What they found was some evidence from some case controls, and based on that evidence, they decided that the data is insufficient to support or refute the efficacy of medicinal marijuana for reducing frequency of seizures. The AAN also concluded that there's not enough information to show if medical marijuana, including smoked medical marijuana, is safe or effective in neurological diseases, particularly motor symptoms in Huntington's disease, tics and Tourette's, cervical dystonia, and for seizures in epilepsy. The AAN also found that there were safety concerns with using medicinal marijuana. Side effects such as nausea, increased weakness, behavioral or mood changes, suicidal thoughts or hallucinations, fatigue, and feelings of intoxication. Mood changes and suicidal thoughts were of special concern for people with MS who are at increased risk for depression or suicide. And in general, medical marijuana is prescribed only as a treatment for use when standard treatments have not helped. So even if the federal government decided that they were going to run a randomized controlled trial looking at marijuana in epilepsy, the process is a long one. It would take at least 10 years for it to receive full approval. It would have to go through various stages, including preclinical research, phase 1, 2, and 3 trials. And then after it met the FDA drug approval process, it would have to be approved by other governing bodies, including the National Institute of Health, the Drug Enforcement Agency. So it's a long process to get a drug approved. Politics also plays a pretty large role when it comes to the use of medicinal marijuana. In August 2013, a father confronted Governor Chris Christie in a diner, the father of a little girl with Dravet syndrome, and he confronted Chris Christie about the delay in signing into a law that would make it possible for his daughter to receive medical marijuana. At that time, medical marijuana had been legal in New Jersey since 2010. However, the regulations required that 3 doctors needed to sign off on a prescription. There was a ban on edible forms of the medical marijuana and a limit on the strains that dispensaries could actually grow. The following month, New Jersey passed the bill 2842, which set no limitation on the number of strains and allowed for edible forms of medicinal marijuana. The state of New Jersey Department of Health has a medicinal marijuana program that provides the latest news and program updates for New Jersey, and states that it's committed to the effective implementation of the New Jersey Compassionate Use for Medical Marijuana Act. Through this particular site, you can find alternative treatment centers. Currently, there are 3 alternative treatment centers that are operational in New Jersey. There are 3 others that are pending. The New York Times recently released an article saying that Connecticut, while it allows medical marijuana, has encountered some difficulties when it comes to trying to dispense it. And the reason for that, or one of the reasons for that, being that it's been difficult for sellers to find dispensing locations approved by zoning boards in towns and cities. In the Daily News recently, there was an article suggesting that medical marijuana could be legalized in New York this spring. So while we're seeing states start to expand their medical marijuana laws, the reality is that marijuana is still illegal according to the federal government. It's a Schedule I drug, meaning that it has a high potential of abuse. There's no currently accepted medical use, and it's illegal to create, distribute, dispense, or even possess. Some of the disconnect between the states and the federal government has created medical marijuana refugees. So people who are moving across state lines to legally obtain the drug that they feel for them has some medicinal value in states where it's legal for them to be prescribed the medication. And some of the states that allow the medical marijuana are states like Colorado and Washington. The American Academy of Neurology states that scientific research on the use of medical marijuana in brain diseases finds certain forms of medical marijuana can help treat some symptoms of MS, but do not appear helpful in treating drug-induced levodopa movements in Parkinson's disease. There's not enough evidence to show medical marijuana is helpful in treating motor problems in Huntington's disease, tics, in Tourette's, cervical dystonia, or seizures in epilepsy. The American Epilepsy Society recently stated that the recent anecdotal reports of positive effects of marijuana for some individuals with treatment-resistant epilepsy give reason for hope. However, we must remember that these are only anecdotal reports, and robust scientific evidence for the use of marijuana is lacking. The lack of information does not mean that marijuana is ineffective for epilepsy. It just means that we do not know if marijuana is safe and effective for treating epilepsy, which is why it should be studied using the well-founded research method that all other effective treatments for epilepsy have undergone. The Epilepsy Foundation states that they support the rights for patients and families living with seizures and epilepsy to access physician-directed care, including medicinal marijuana. The Epilepsy Foundation calls for an end to DEA restrictions that limit clinical trials and research into medical marijuana for epilepsy. It also believes that an end to seizures should not be determined by one's zip code. And so it's actually a pretty exciting time in epilepsy, being that we can begin to have a conversation about therapies that will potentially improve the quality of people's lives. And despite this disconnect between state and federal governments, things are changing. They're changing slowly, but they are changing. For instance, today at Northeast Regional Epilepsy Group in Hackensack, we submitted our investigational new drug application to the FDA to start our own marijuana trial. People with epilepsy that we see in the hospital and office have been asking the question, what about marijuana for my epilepsy? And this is something that we want to be at the forefront of in order to continue to provide quality care. Thank you for your time. If you have any questions, please email Tijan.